So welcome everyone. I just put up my various affiliations here. I should point out I have no conflicts to disclose. None of the medications I'm describing here are produced by companies that I work for or consult with in any way. And all the research that I present is in the public domain, and some of it we have published with funding from the NIH. So just to set the table, and this is unnecessary, I'm sure, for many or most of you. We're talking about a group of illnesses that I'll refer to as the schizophrenias, non-affective primary psychotic illnesses. Broadly, as we know, they have several distinct clusters of symptoms. So like any syndrome, this is a convenient way for us to recognize an illness that includes a mix of symptoms that are experiences that people have that are not normal, not usual, and also signs. These are observable behaviors or aspects of speech that give us the same clue. And it's convenient to cluster these amongst the so-called positive symptoms. These are symptoms that individuals normally, that is the normal population, would not have. And so there are additions to mental experience and hence positive. And within these, as are familiar to many of you, I won't read them out. We can think about reality distortion and disorganization. Often what people mean when they use the word psychosis is specifically these positive symptoms. And then there are also the so-called negative symptoms, as in indications of an absence of what the normative population usually has. Often tricky to detect. As you might imagine, these are functions that many of us take for granted. And so it often takes expert assessment over a longitudinal period of time to be able to really reliably detect these changes that can be quite disabling and often distressing, not to the individual themselves, but often to caregivers around them. And then there are other broad domains, cognitive deficits, often subclinical, difficult to detect on regular clinical exam, but a more detailed cognitive assessment or neuropsychological assessment will often find these different kinds of deficits. And finally, and maybe this may be surprising to some, but affective dysregulation is common amongst the primary psychotic disorders. So even if you do not have major depression with psychosis, or you do not have bipolar disorder that can have psychotic features, schizophrenia spectrum disorders are routinely, individuals with these disorders are routinely affected with changes in normal mood that can look like clinical depression and can even look like mania. And we can talk a little bit more about that. But I mentioned these only to indicate that our medications work most on some of these domains and not others. Broadly, this is a very schematic and simplified cartoon. And I've put it up here so individuals, many of you can look at it later and have a look through the different hypothesized ways in which the neurochemistry of individuals with schizophrenia is affected. So the current working model really operates where the two orange circles are to the top right of the screen. So we think there are many upstream events that result in changes in dopaminergic functioning. The medications we currently use are restricted in their impact primarily to the dopaminergic systems. And so much of what I'm presenting today about practical pharmacology is really interfacing at this point in the neurobiology of the illness. But I put this up just to point out that we don't think this is the cause of the illness, but most people with psychotic symptoms have impairments in these dopaminergic systems. And that's where many of our drugs, at least all of our current antipsychotics, appear to act to reduce psychotic symptoms. There are exciting new developments that are targeting other neurochemical systems and new medications that we're expecting that are coming potentially to market, we hope. So I put this up here in part to prepare us for a future where we might be able to target other neurochemical systems in the future. And this is another version of the same point, but focusing just on the dopaminergic system. As many of you may know, dopamine is produced in the brain and circulates through distinct neurocircuits. And unfortunately, when we give our dopamine blocking agents, we cannot be specific and tend to block dopamine transmission to differing degrees in all of these circuits. We think that when it comes to schizophrenia spectrum disorders, dopamine blockers that are acting primarily in 2 and 3, that is the mesocortical and mesolimbic circuits, are responsible for improvements in symptoms. And so these are the circuits we want to target. Unfortunately, we also end up targeting 1, the nigrostriatal circuit, which often leads to extrapyramidal side effects, movement disorders, Parkinsonism. And sometimes we also target the tuberofundibular system. So it disrupts endocrine regulation, which can cause prolactin elevation that, especially in young women, can be problematic. So in some ways, we are trading off when we dose antipsychotics and trying to find an ideal place in terms of dosing and in terms of choice of medication where we get a maximal effect on 2 and 3, try to reduce our effects on 1 and 4, and if not possible, add medications or make adjustments to reduce side effects. But this is still a useful guiding heuristic on what your medications might be doing in the brain that might prepare you for the kinds of side effects you would have. Drilling down even more to one level below, and I promise I'm going to move on soon to sort of practical issues with the antipsychotics. This is from a paper that nicely ties together some of the thinking around dopamine. And the idea is that dopamine really helps explain not really schizophrenia, but psychosis, mostly the positive symptoms of psychosis. So the subtitle to the slide now really should be the dopamine hypothesis of psychosis, because it doesn't explain cognitive symptoms and affective dysregulation as much. But it's really a way to think about how blocking dopamine action at the postsynaptic receptor might help alleviate the symptoms of psychosis. So some of the thoughts are broadly that a variety of stress factors, neurodevelopmental risk factors, environmental factors like cannabis use, for instance, might act via increasing the amount of dopamine in the presynaptic receptor. And so this is the larger on the left side terminal here. And that excessive release may be related to the experience of psychosis. And some investigators have called this a state of aberrant salience, which is attributing too much importance to what the rest of us might think of as coincidences, things happening in the environment that are interesting, but maybe just not worthy of a lot of our attention. Whereas someone with high levels of dopaminergic tone might pay much more attention to trivial things and then make connections between them that might result in the descriptions many of you have heard of people having ideas of reference, paranoia, and so on. It's a conjecture that's very interesting to at least think about how what's happening neurochemically might express itself in a person's verbal utterances and their experiences. But this brain-mind conversation is really preliminary. It's just a way of thinking about this and explaining it to families and even patients who might be curious about why it is we're intervening at a neurochemical level on something that's really about a change in mind in a person's experience. But of course, these things are connected. They're the same. We just have different languages to describe them. And so this is one idea of how dopamine imbalances, which we know are the case in psychosis, might contribute to the experience that people have. So returning to the point I made earlier, we can target positive symptoms with our medications. Sadly, we don't have any strong empirically based treatments for negative symptoms pharmacologically. And I'm going to speak a little bit later about psychosocial interventions. But since this is a talk focused on medications, I'm graying out negative symptoms as something we don't really have targeted treatments for medication-wise. But the same is largely true for cognitive deficits, although there are several promising trials of different agents. And of course, we do have treatments for affective dysregulation. And individuals with schizophrenia spectrum disorders will often benefit from antidepressants, just like individuals with depression do, and might often benefit from anti-manic agents as well. So I'm moving on now to describing sort of broad principles, and there's a lot to say about each of these bullets, but I'll go over them quickly as sort of guiding principles that we use at STEP. On top, of course, is shared decision-making. Nothing works without an individual patient and often their family members who understand and are willing to collaborate on the taking of medications that for the most part are voluntary, except in very narrow circumstances in inpatient units and other kind of restrictive settings. So thinking really about treating the illness over the long term as a chronic illness, it's vital to have a shared decision-making ethos guiding decision-making, even if, and especially when the individual patient lacks insight or awareness that they have an illness. And I would propose to you, and many of you would already know this, that it is in fact possible and in fact common to have effective shared decision-making, even when the young person denies they have an illness. We privilege empirical studies in humans. That is to say, when a drug has been studied in humans rigorously, often and in controlled trials, and this is necessary for FDA approval, but even in post-marketing studies, where effects in actual individual patients are important to know. And we privilege that over theoretically based proposals in the literature that often can lead to these larger definitive studies. And we lean on them only when we have reached the edge of what the empirical literature suggests as the next step. And hopefully this will become clearer as I go through the later slides. And then we privilege that, of course, over clinical experience. But by this, I mean not to devalue experience, but just to suggest that what any individual prescriber has encountered, what medicines they've used, and which patients they've seen, most importantly, are often a very small and often unrepresentative sampling of what the larger population of people with early course psychosis and even chronic schizophrenia represent. So, to make this very clear, the risk of agranulocytosis on clozapine, while it was only detected by alert clinicians in initial reports, our sense of how common this is could only come from very large population studies. And so any individual clinician, if they were to prescribe clozapine over the course of a lifetime of practice, may actually never see a case of agranulocytosis and so may be unaware of this risk. So it's a somewhat obvious point, but I think it actually applies not just to clozapine, but in all of our practice of medications, and indeed across medicine, that we want to be calibrating our individual experience using a medication against empirical studies, and also to be aware to some degree of the theoretical basis of their actions, so we can be cautious about possible side effects and monitor for them. It's important to use the minimum effective dose, and this has implications obviously for tolerability and for whether individual patients will remain on the medications, which can be pivotal in whether or not they relapse and end up not able to recover full functioning. We try in general to avoid combination treatments. Sometimes they're necessary, but often they lead to challenges with adherence and, of course, interactive side effects that make them a poor trade-off in general. It's important to regularly reassess for response to interventions. And this is to make the point that just because a study shows it's effective in general in populations, individual patients vary and are heterogeneous. And so we must be humble and make sure that even if we're using what appears to be an effective treatment, that we're checking, and if it doesn't work, to try something else. And finally, especially in the context of early psychosis, we should raise our goals and treat to remission. And I'll say more about this, but the good news is that almost any medication works if delivered in a tolerable dose by attentive prescribers over time. And so our expectations should be much higher for what we can get to with these individual patients. And I'll say more about that in a few minutes. So what I was going to focus my presentation on, and this is partly based on feedback from presenting versions of this over many, many years, on what prescribers who have practical questions, who are seeing patients in the clinic, are often trying to respond to. I put up a textbook that I think is really at this point the gold standard for practical advice on what to do in a variety of situations, how to manage side effects. I keep a copy at my desk. It's also available online, and I highly recommend that for those who are seeing patients, this is a good first place to go to for practical advice. What I'm going to do is not try to obviously replicate the manual and all the detail, but address maybe 4 major questions that keep coming up that I think are relevant to practice. And I won't go in this order, but I hope that by the end of the talk, you'll feel like I've responded to all 4 of them. Which medicines to choose, what dose, how long, and how much to expect in terms of improvement. So again, not a slide that I would like you to necessarily go through now, but just to make the point that these medications, and I'm talking here just about those classified as antipsychotic medications, have complex actions on multiple receptors in the brain for which we have variable understanding and knowledge about their impact on side effects. But often we have a sense of which side effects are likely with which medication. And although the antipsychotics are largely similar in their effectiveness, they do vary quite substantially in their impact on other receptors and side effects. And so sometimes this makes the difference in terms of choosing a medication that is tolerable to an individual patient. And patients differ, of course, in their sensitivity and willingness to manage different kinds of side effects. So I'm starting off with what dose. Many of you have probably seen a version of this, and it's useful to keep in mind, which is there's sort of a Goldilocks range, which is the green area that you're aiming for, where on the y-axis is the percentage of D2 receptors that have been blocked by the antipsychotic medication. And you can imagine this in the mesolimbic circuit, for example. We obviously can't see the level of occupancy when we're treating patients, but this is based on several PET studies that directly look at receptor occupancy. And it's fairly established empirically now that we get the best effect with individual patients when we're able to dose them such that the occupancy levels are between 60 and 80%. So increasing occupancy gives you diminishing returns and often increases the side effects, whereas an occupancy much lower than that leads to less effectiveness in treating positive symptoms. So in clinical practice, we're not obviously looking at PET receptor binding. We're relying on dosing, and most dosing guidelines are roughly calibrated to try to get to that level of occupancy. So following general guidelines is what we do. Some caveats. One, there is in fact a lot of variability between patients on a particular dose and how it's metabolized, and as a result, what the brain ends up seeing. So we should be humble and open to the possibility that an individual patient may be quite different from others and might require higher than usual dosing, or sometimes can get by with even lower than usual dosing. But in the main, staying within the guidelines of the range is good enough for most people. The other caveat, sadly, is that even at the lowest effective dose, many individuals suffer a kind of flattening of cognition and mood that may be related to the antipsychotic D2 blockade itself and is not negative symptoms or depression. The good news is it tends to wane in its impact over time, but it is real and sometimes is a cause for individuals to stop medication treatment. And we can talk more about that. I put in clozapine, Seroquel, and Abilify in a different category. The point here, of course, is that they still do act, it appears, by D2 blockade, but they have slightly different profiles in terms of the strength with which they bind the receptors. So they may have advantages in some ways in terms of some side effects that we can talk about. But I think that the story is the same for most of these medications except clozapine, where getting the drug to 60, 80% is what we're aiming for. Again, not something you need to read now, but I'm giving you various resources and how we think about this. What dose? So this is an older table from a paper that I've cited here, and I'm going to keep putting papers here in case people are interested in digging in. But the main point here is that if you look at the near maximal effective dose, which is the column all the way to the right, you may or may not be surprised based on the practice you've seen around you about what that is. I often find that individuals are surprised to hear how low these doses are, and it might mean that you're in a setting where higher than usual doses are often used for more complex cases that are more atypical and not what a typical schizophrenia patient, certainly an early course patient, might require. So it's useful to look at these just to calibrate and get a sense of how unusual the dosing is in your setting. In the US in general, we are at the higher end of these doses for most of these medications compared to Western Europe and the UK. The figure on the left is to make the point that for all these antipsychotics, and risperidone is the example here, they follow a hyperbolic curve. And so it's useful to think about this image is that when you're going from a dose of 0 to 1 or 2, you're often getting the most improvement early on in the dosing schedule. So PANSS is a structured instrument that measures symptoms, and the y-axis is showing the degree of improvement in PANSS. So going further up is better. And you can see that the curve flattens out, which is as you get higher up in dose, you get less and less improvement. And this is consistent with what I showed earlier about the PET receptor finding. So this is the case for all antipsychotics, is you get a lot more bang for your buck when you're starting up on your dosing, and it's going to taper off as you increase the dose. Conversely, when you're tapering off, the same thing applies. So that means that if you're at a dose of 10 milligrams, you can go from 10 to 6 pretty quickly. But once you start getting below 4 milligrams or 2 or 1, you want to actually slow down how much you taper by. So you might taper by 0.5 milligrams every 2 weeks when you're getting lower down in the dosing range. What dose? Again, this is a table from the Maudsley, which is the more recent, and it has more of the recent antipsychotics on it. Again, it would be good to look at these periodically and just get a sense of, in my setting and practice, am I falling somewhere in this range? Or am I seeing doses much higher, which is what I would bet in the US, or maybe even lower sometimes in child and adolescent settings. There's often an interest in trying to dose less, which might be good, but you might end up being in a range that's not as effective. And again, it's worth looking at these manuals periodically to get a sense of where you fit in your own practice as well. So I'm moving to another question: how long? So this comes up a lot, and often it's asked in inpatient settings or acute settings where there's a lot of pressure to stabilize and discharge a patient as quickly as possible. And so it's a very relevant practical question. How long should we wait before switching medications, concluding that this trial didn't work? And this is one study that gives useful information, I think, very carefully done over just 6 weeks. So this is a fairly short-term longitudinal follow-up. The y-axis is weeks, and the x-axis you can regard simply as level of symptoms. So higher is worse, lower is better. And you can see on top left, there's the largest proportion of patients have kind of a steady, slow, not very dramatic reduction in symptoms. On the top right are the early fast responders. They're dramatic. And some patients have this, and it's great when it happens. And I suspect for those individuals, prescribers don't keep increasing the dose because they're seeing a response right away. There's the group on the bottom left, unfortunately, where they are actually getting worse over time. And so the trajectory in the first week is what the trajectory is going to be at week 6. So it might make sense if they're heading in that direction after a week to switch or to increase the dose, depending on what dose you're on. And then there's the group on the bottom right, again, a dramatic response. There is heterogeneity is the point, mixed different groups. And we don't sadly have a way to predict that with any blood test at admission. So early monitoring and careful attention in the first few days can help often determine which group the person is in and then how you might respond. So in the outpatient setting, this is a more relevant figure. And the point here is, so on the x-axis is weeks of treatment, and you can see it goes out all the way to 84 weeks. It's much longer term. And on the y-axis is response. So here, the further up on the y-axis, the better, the more response individuals have had. And the main point here is that you'll see between week 1 and week 6, most of the improvement that's going to happen has happened. So, or maybe to put this more correctly, if you're looking at the proportion of people who've had at least a 20% reduction in PANS, and let's say that's a good measure of response, most of the people who would have that response have had it by 6 weeks, certainly by 8 weeks. And if you stay on the same medication, some folks will respond at 12 weeks, and there's a small proportion even at between 12 and 16 weeks that will have a response, and so on. The point is that if you stay on the same medication at the same dose with people with early co-schizophrenia, time is your friend. More and more people will respond. But as you get out further along beyond 2 months, fewer and fewer people who have not already responded will respond. So there's less and less rationale to keep them on. I mention this only because sometimes individuals are unwilling to switch medications or unwilling to increase the dose. And if they've shown some response and they've tolerated it, it is sometimes reasonable to wait in an outpatient setting where you're not concerned about severe enough symptoms, a lot of suffering, risk for aggression or self-harm. You have the luxury of time. There is some rationale to sort of go slow. Moving on to another question, what should we expect in terms of improvement? And I have only good news here. So this is in the context of early course schizophrenia, individuals in the first 3 years, even up to first 5 years of psychosis onset. This was a study where they essentially, in a systematic way, gave individuals one medication, which was either olanzapine or risperidone, which at the time were the two main second-generation antipsychotics. And if they didn't respond, they switched them to the other one. So if they had olanzapine first, they got risperidone next. And if they didn't respond to both of those trials, they got moved to clozapine. So these were 3 successive trials, each for 4 weeks. And obviously, this is in the context of a study. So they had resources and research assistants to measure symptoms every week and report back to the prescribers whether or not someone had responded or not. So under fairly ideal monitoring conditions with good measurement-based care, the overall response rate was 75%. This means that 3/4 of individuals by the end of the study had a significant response to one of these 3 medications that we've had available for many years now. A Of course, the big caveat here is they were assisted with frequent symptom measurements so that prescribers could respond if there wasn't improvement by changing the dose. And the prescribers were also very familiar with managing the side effects of this medicine. So they were able to help patients tolerate side effects more commonly than would be the case in usual practice. A more recent study, which is actually cause for even more optimism, this was done in many European sites. That's why they used amisulpride, which is not available in the US. But the point is the same, is that they had one trial, and if individuals responded, they just kept them on the medicine. They took the non-responders and tried a second medication, which was olanzapine. And again, they had a significant number of individuals the subgroup who didn't have a response were moved to clozapine. And actually, I should correct myself. This was not response, this was remission. So unlike the previous study where they were content if individuals had a 20% or so reduction in symptoms, in this study, they wanted individuals to look essentially like they had no symptoms, or at least symptoms that could only be detected on structured assessment. So they looked symptomatically really well. And again, over a trial that took just 12 weeks, again, in the context of a clinical research study, about 64%, if you counted all comers, had remitted over 12 weeks. And if you counted only those who didn't drop out of the study, who went through all the steps, it was close to 3/4 again who had remitted. So the point here is that with our current medications, we can get a significant percentage of individuals to not just respond but to remit. And in practical treatment settings, this can obviously take longer than 12 weeks. Individuals drop out of care, they don't get frequently assessed, and so on. But I think it's a reasonable goal within 6 months, and especially within a year, to try to get individuals to adhere enough to treatment with medications that we already have, to expect this level of remission for 3/4. A point I've made before, and we should make again, and many of you know, there's significant heterogeneity. Individuals with these illnesses are different from each other. They share a lot, which is why we can utilize the evidence from population-based studies to treat them effectively. But we should always be ready for surprises. Quite separate from their illnesses, of course, these are remarkable individuals. So their capacity to tolerate even severe symptoms varies between them. But we are a long time away from the time of Felix Garcia. This is a flamenco dancer who was painted by his friend, Picasso, at a time before we had any antipsychotic medications. And sadly, this is still the image imprinted on many people today in terms of media representations. But it represents a vanishingly small proportion of individuals with psychotic illness. And this is not so much even a failure of medication treatment as it is more wraparound psychosocial care. So no one should be in that position now, but certainly since medications have become available, that level of symptomatic severity is really unacceptable. And if it does occur, we have better ways to support those individuals in various kinds of psychosocial activities and housing and supports that would not leave them in a position of being symptomatic and homeless. But there's much, obviously, more to say about that. Broad principles to keep in mind is maximizing tolerability and adherence. And I put in some points that I won't read them all out, but the stakes here are that without tolerability and without adherence, individual patients would lose the benefit of being in remission fairly quickly after the onset of a psychotic illness. So much of the work here is in helping them tolerate, manage the side effects of these medicines that are not pleasant to take, but if taken on a continuous basis, can have a dramatic effect on positive symptoms. And that can provide a good, solid foundation upon which to build all the other psychosocial interventions that can help a young person rebuild their life. What does it feel like when you take these medications and you respond to them? So this goes back to this question of how much improvement to expect. This is an interesting study that looked at what early on, how do people improve and exactly in which dimensions? And the broad point here is that when you start an antipsychotic on someone who's acutely, severely psychotic, you will see the most immediate response on what they call the behavioral impact, but what is commonly seen as a reduction in obvious disorganization, aggression. People become much calmer without becoming sedated. And this was often this was the first way in which antipsychotics were discovered, is that individuals become calmer, but they don't fall asleep. It's a calming with intact awareness. The what follows soon after often is that they become less emotionally involved with delusional material. So they might remain still delusional, or they might still experience hallucination, but it preoccupies them and distresses them much less so. And this follows too in terms of their thinking, their cognitive preoccupation. They're much less engaged with it. The domains that tend to improve less, at least immediately, but might slowly improve over time, is their sense of conviction, which is the point 4 in this slide, and the ability to take an external perspective. And what this probably means is they still remain often convinced when you query them about their belief that, for example, someone is following them, their neighbor is out to get them. Even supplying contradictory evidence may not allow them to take that perspective. Nevertheless, the improvements in 1 through 3 are often so impactful and helpful that it can help keep a person engaged in treatment, help them return to their life, school, or work. And 4 or 5 can be worked on later. It is not a loss to find yourself with someone who isn't showing a reduction in their conviction. But if they're calmer and they're less preoccupied with the delusional material, that's a good early win. You've probably seen many of these in the usual manuals, but the point is early on, we're often monitoring for adverse events that are different from the ones we want to be worried about later on. I put this up only to point out that much of the time as prescribers, we're very preoccupied with the early side effects, but it has become increasingly evident over the last decade that what shortens the lives of individuals with schizophrenia is the metabolic side effects of these medications, weight gain, the secondary diabetes, hyperlipidemia, the kinds of things that shorten all our lives for cardiac illness impact individuals with schizophrenia particularly harder. And so once the early side effects are addressed, it becomes important even then to start monitoring and thinking about the risk for weight gain and glucose and lipid abnormalities. This is an old study that has gotten a lot of citations, and it's still largely true in terms of its grading of drugs. And I put it up here just to make the point that when you're choosing a medication, risk of causing weight gain should be an important parameter in the choice, even though they might be quite tolerable to the individual patient in terms of acute side effects, and even though their effectiveness is unquestioned compared to the others. And so you'll see later on, it informs the way in which we stage treatment at STEP by, for example, not using olanzapine as a first-line medication because there are alternatives that are less likely to cause metabolic disturbances and are equally effective. And this is just for those interested in the time course, they do separate out at 1 year. Recent evidence suggests that most antipsychotics, maybe all, do have some tendency to cause weight gain. And so we need to monitor individuals no matter what they're on. But some tend to cause much more dramatic and rapid weight gain early on. And it can be very difficult to lose weight in our individual patients, but also for all of us. So it's much better to try to avoid it in the first place. So this brings me to my second principle, which is after thinking about immediate tolerance, tolerability, and getting them on the right dose to treat the psychotic symptoms, that one be very proactive about reducing cardiovascular risk. There are many bullets here that I'm leaving up really for people to look at later, but the point broadly is to offer the usual lifestyle counseling, smoking, exercise, diet, to monitor for lipid abnormalities and to check weights. I would recommend ideally every week for the first 3 months on an antipsychotic and at least monthly after, as a way to making sure that we don't lose track of what's happening and have a chance to readdress smoking and exercise and diet as risk factors, especially diet, which is the big driver in antipsychotic induced weight gain because of effects of these medications on increased appetite. And there's more to say here, but just to make the principle clear. And finally, and we won't unfortunately be talking much about this today, although many of the other presentations are focused on this, is the medications should be integrated, of course, with all the other interventions that are occurring to help a young person get back to their life. And so there may sometimes be trade-offs between when one increases the dose and risks dose-related side effects, and when an individual might need to have to be alert and awake during a certain week when they're taking an exam, for example, and prefer not to make med changes. Alternatively, a good time to make changes might be during the summer months when people are on vacation from college, where you can try things that might be risky to do to destabilize someone when they're in a high stakes situation, either taking a class or starting a first job. And communication, of course, with all the other providers who are involved in the care of the patient when these changes are being made would be critical. I put this up again for some prescribers who've talked to me in the community. In the early course of the illness, especially, one is often moving through different phases or cycling through different phases, unfortunately. So it's rarely the case that a person comes in, you start a medication, they get stabilized, and then they start proceeding towards recovery. We would love if that were the case. In actuality, what often happens is individuals get on a medication, they get much better, they feel so well that they decide they never had an illness to begin with. They stop the medication, they relapse, they're back in the acute phase. And one often cycles through these repeatedly where you're using medications initially for an acute phase and then you're trying to stabilize them, bring them down to a minimally effective dose. They're doing okay, and then they relapse again, and you go, sometimes it feels like you're going right back. The point here, of course, is that this is common with people early in the course of illness, going through these cycles with an individual and getting them on the right dose and trying to understand why they're stopping their dose and whether you can proactively address side effects will often help move them out of this cycle and on towards a more stable recovery. I put this up because I've often been asked about whether we use an algorithm. We don't, although I presented to you 2 algorithm-based studies that I think could be very effective if one had the resources to measure frequently and follow a systematic approach. But I think there is a way to implement that in usual practice. And this is a staged strategy. So what I mean is in stage 1, you have an individual where you don't know which medication they did or didn't respond to. And it's reasonable to trial any medication, given that I've told you, except for clozapine, which is in a different category, all the other antipsychotics are about equivalent to each other. I would include first generation antipsychotics as well here. The reason I put in SGAs first is in most consensus guidelines for early psychosis, these are often better tolerated in terms of acute side effects than Prolixin or Haldol. Here, one should pick the medication that the patient is willing to take and that you can get them on at a good dose that's also tolerable to them. And we put except olanzapine for the reasons I mentioned before, which is to say it's often very well tolerated acutely. It causes lesser degrees of EPS. People are often happy on it. However, it causes very rapid weight gain and can sometimes present a conundrum to the outpatient service that's inheriting the patient, who might need to switch off the medication to avoid catastrophic weight gain and then risk for diabetes. So this is not to say that one must never lose olanzapine, but we try to not start it as the first agent, given that you will expect a response with the first agent, no matter which one you try. And the goal is to think about remission. So while in inpatient unit, a reasonable target might just be response, enough improvement to get them safely off the unit. What should continue in that stage, which is still stage 1, is to keep adjusting the doses and getting the patient to remission. Before moving on to stage 2, which would be a second trial, it's important to assess for the adequacy of the trial. So it's possible that in stage 1, individuals have had actually many different exposures to different antipsychotics, but none of them were an adequate trial. They could have been interrupted because of side effects. And it might mean that the medication is still a good one, but it just needs to be prescribed more carefully at a slower dose or increased more slowly with some adjunctive treatments. But it might be a no-go because the patient just says, I've had it, I'm not going to try it. So that is a trial that's been interrupted. It's not an adequate trial. It could have been interrupted, as I mentioned, because the patient has done so well that they decide to stop it. And that should not be counted as a failure and a reason to move to stage 2 or a different medication. Sometimes, sadly, it's stopped because of insurance coverage issues and confusion about which medication will be covered and which won't. And so it's important, if you're inheriting a patient from another service, to first inquire before you start a different medication why the prior one wasn't working. And it may have been that it actually was working, but it was stopped for all these other reasons. If one finds that there's a truly inadequate response, they've been on the medication long enough and they either haven't responded or the response has been not good enough, it's not heading towards remission, then that's a reason to go to stage 2, which is a second trial. And I describe these deliberately as stages and not medications because a patient might cycle through many medications to get through the next stage again for the reasons I mentioned. They might interrupt the dose, they might not lose coverage, and so on. And so there's a second trial, and many consensus guidelines suggest then that if the first trial was an SGA, it makes sense to trial a first generation in the second. Another thought that I'd put in there and is to consider long-acting injectables. They are often the reason why individuals don't respond. And as prescribers, we are pretty bad at guessing who's actually taking their medication. And even when they say they often aren't taking them all the time. It's hard for all of us to remember. So if one of these two stages included a trial of an LAI, it would help remove the possibility that you inadvertently moved to stage 3 while one of those trials was actually inadequate. The patients said they were taking it, but they actually were not. Another reason LAIs are great, actually, especially in young individuals, is that they do lead to less dose-related side effects. They are more tolerable in individual patients because they're exposed to a much lower dose over time with the injection. And many young individuals like it because of the convenience. They don't have to carry around pill bottles. It's less exposing to their peers in a dormitory setting or shared housing. They come in once a month, get a medication, and they're done. Sometimes it's useful to consider an LAI even if you're getting an inadequate response. They're taking it, PO, for some reason they're not responding at a dose you'd expect. This could be because they're a fast metabolizer, and an LAI will get around that effect. So switching to an LAI version makes sense. So this obviously has implications for which medication you choose. It would be great if you picked a medicine in stage 1 that the person responded to, that you could then convert them or have their outpatient provider, if you're an inpatient provider, have them convert to an LAI. Even better if you can convert them before they leave the unit. In practice, this can be tricky with a young person who's not even sure they have an illness and may not want to commit to treatment. But I put that there just to say it's a consideration and a very important one in first episode psychosis. And often getting a person on LAI can be the difference between having them be stable for many, many months to years versus cycling through the different phases I described earlier. Once you're done with the 2 stages, clozapine is effective in at least a third of individuals, and in FEP, likely an even greater percentage. But obviously, this is a bigger lift for a clinic, and we can talk more about the kinds of supports you can rely on to help with dosing and managing people on clozapine. Once you're past stage 3, you're past most of what the empirical evidence can provide good guidance on. And there are many ways to go, starting adjunctive medications in a careful, serial way, trying it and then stopping it if it doesn't work and trying something else. ECT can be an option. And enrolling in local clinical trials that are targeting individuals who do not respond to clozapine can be another good option for individual patients. And this is a good point for me to let you all know about the consult service. So this is a consult service for clinicians. The best way to access it is to go to our website to enter just a brief questionnaire that tells us who you are and how to reach you. No PHI, nothing about the patient, but it helps us understand who should respond. And this is a chance to engage with any of the clinicians at STEP to talk about anything in terms of management, but specifically in terms of managing antipsychotics, we are happy to talk and provide some assistance. This is a busy slide, but just for me to make the point that there are many other situations where it's either not clear what to do, or the things you need to do to manage these kinds of challenges require a whole team and a kind of ordered, structured process. Just to pick one example from all of this, just arranging ourselves in a way that we collect regular weights and monitor it in the clinic is actually quite a challenge and requires setting up workflows where this becomes routine and where a clinic clinicians and prescribers get regular feedback on where weights are so they can respond appropriately. And I list several others where care pathways can be helpful to set up in clinics. So for those of you who work in clinics with others, thinking about how you want to organize your care processes so that you have a systematic approach to how you would target these challenges can be very helpful in making your work a lot more effective. So again, we're happy to talk about these. For example, negative symptoms are often, it's helpful to have an approach where individuals can be, especially family members, can be educated about the presence of these symptoms so they don't inadvertently blame the patient for being lazy. But also activities can be arranged around the person to include them in activities so that they aren't suffering social exclusion, which can be another problem layered onto negative symptoms. And it can be useful for a clinic to collaborate around how to have standard responses to this, and maybe even divvy up the tasks of how to do this with families so that patients get the best care for all these different domains. And I list them here. Some of them obviously intersect with medications, and some are areas in which the medications aren't helpful or actually cause active problems in these domains like cardiovascular risk. And so I just wanted to put that larger context in place. And this is my final slide, but I think it's important to think about how medications specifically intersect with a larger system of care. So we want all our care systems for all chronic illnesses, whether it's diabetes or high blood pressure, asthma, psychosis, to have these domains. They're safe, effective, patient-centered, timely, efficient, equitable. When it comes to medication specifically, I've tried to peg some of my comments into these areas to make the point that medication interventions are vital to improve all these domains of quality of care in a service. And they need to be integrated, of course, with all the other services. The prescribers who are involved with patients need to contribute to these different domains, to be timely, responsive, to collaborate with community services. All of this, of course, will make much more effective the actual medication that you write for and the patient hopefully swallows.